I'm very proud of Dr. Boom. He is the CEO and has been for 9 years of Houston Methodist. He's been with Houston Methodist for 23 years. If you look at his resume and the website, you'll see he went to the best schools in the country and is still actually a practicing doctor with a internal medicine practice. But he spends all his time recently, I believe, on helping the world and certainly Houston solve the COVID-19 problems that are facing us today. So Marc, I want to start this evening by just telling you, I want to cover 4 basic topics. I want you to help us, particularly us non-medical people, understand the virus. I want to talk a little bit about the situation in Texas, but of course, specifically in Houston, which is what on everybody's mind here. And part of that is, what is the readiness of our healthcare institution? I want to talk a little bit about healthcare professionals and how finally is this going to end? What's the future feel like? Okay.
Okay.
Great. So let's start to begin with. What is a coronavirus? Somebody told me that these pictures with these spikes on it means, and corona basically means it's a crown. What is this virus?
No, that's exactly right. It's named because of the way it looks. It has spike proteins on the surface that go out just like the spikes of a crown would go out. It's a family of viruses. It's actually a very common family. In fact, there's 4 types of coronavirus that circulate around just like the rhinovirus and some other things as, it's not the common cold, but symptoms like the common cold. In every year, we test for that and we see lots and lots of patients with those. And then within that family, there are some viruses that sometimes jump from animals into humans. We've seen 3 major instances of that. The first was SARS back in 2002-03, which of course was much more lethal and fizzled out quickly, in part because of that. And I can explain a little bit of that later. And then 2012, we saw MERS, which was in the Middle East, probably jumped from camels, or certainly camels are a host of that. And now we have the new one. It's called SARS-CoV-2. So the original SARS virus is SARS-CoV as the virus. This is SARS-CoV-2. MERS was MERS-CoV. And so that's what we're dealing with now. This one probably jumped from bats. We don't know that 100% sure, but it had significant ability to jump from person to person, which is why we're in the situation we're in today.
So the animals themselves don't suffer from the same problems that we suffer from?
Not necessarily, right? And bats in particular have many, many viruses. There's something about bats that they don't have an immunity. They get the virus, but they actually don't have symptoms from the virus. They just carry it for many, many years. And so we think this was bats. We think probably SARS, the first SARS was also bats, but there's many other animals that can be impacted as well.
So we call it COVID-19 is what we're using now. Does that mean there are 19 variations of this particular COVID-2? You're confusing me here.
No, I know. So SARS-CoV-2, which we don't see that much in the press, is actually the name of the virus. COVID-19 is the name of the disease the virus causes. And so that actually is short for coronavirus disease 2019, because that's when it showed up. And so that's where the name came from. So the name of the virus is SARS-CoV-2. The illness that people are getting is called COVID-19.
Fantastic. Now, this particular brand, I was in Singapore during SARS and remember it was scary, but it certainly didn't spread like this. And one of the things that we all are testing today is this is so virulent. It's moving so quickly. What is special about this one that didn't happen, for example, in MERS or in SARS in earlier years?
Yep, probably 2 things, but probably the biggest is actually both of those pretty uniformly caused very severe disease. So if someone got it, they got really sick, they were identified, they were quickly isolated, quickly treated. In the case of SARS, 10 to 15% mortality rate. In the case of MERS, something like 30 to 40% mortality rate. So public health officials and others were able to quickly kind of identify those individuals, get around them, track their contacts, etc. With this virus, it's good news, bad news. The good news, it's much, much less lethal, and we'll talk about some of those numbers. But it also has, we think, as many as 25% of people who get it are asymptomatic, and some other portion of them are minimally symptomatic. And so it spreads very easily, oftentimes by people who don't even know they have the disease, or in a couple of days before they start showing symptoms. And so it spread and got out of control much more quickly than those other 2 did because of that.
So that's why in the world today, I just noticed today, we just went over 1 million
We did.
1 million cases in the world with over 51,000 deaths. And that's the reported cases. Could you venture a guess, because of all these asymptomatic people? Is it 2 million, 5 million? Is it even more? Because there have been some wild predictions of how many cases there actually are out there.
Yeah, it's really hard to say. Nobody really knows the answer to that. If we made the assumption, which is an inaccurate assumption, but if we made the assumption that everybody who had symptoms had been tested and diagnosed, and that was 1 million and 25% of people were asymptomatic, you could do the math and, it'd be 25% higher than that, or a little more than that, higher than that. The reality is testing has been so limited throughout the world, particularly in the United States now, that there's many, many more people who have it, who have milder disease, who haven't even been tested or don't even know they have the disease yet. So I do believe the number is far higher than that.
So we have now gone basically during the month of March, now we're in April 2nd, we've gone from basically zero, at least reported cases in the United States, to this evening, 236,000 cases with almost 2,400 deaths across the country.
Yep.
That is exponential growth. And
Nope.
and this is the 1 begets 3 begets 9 and so forth, right?
Exactly. So there's something called the R0 or the R0. Just think of it as the number of people each person who's got the disease infects. And it's somewhere between 2 and 3, for this virus. And versus flu, which is 1.3. So what happens with flu, you may infect 1.3 other people on average. The mathematics of that go quickly, but the mathematics of 1 infecting 2 or 3 is massively different as you get generation after generation of spread out there. So for example, with a 2.5 spread and a 5-day time between people who are infected, from day 1 to day 30, one person ends up chaining this out to over 400, I think it's 406 people with that math. And it's actually, that's, I believe, an underestimate, because the median time to symptoms is about 5 days, but people are probably infected for 2 days before that. So it may even be more than that. And that's really why this grows literally like wildfire.
Do we know if you're infectious only during the asymptomatic period, or are you infectious during when you actually are feeling the symptoms of the disease?
So we believe you're infectious about 2 days before you show symptoms, and then you're going to be infectious throughout the time that you have symptoms, and perhaps on average, sometime after that, probably a total of about 14 days of infectiousness for individuals. Now, of course, as you study that, some people may go longer. There may be some even carriers of it afterwards that don't clear the virus. But in general, that's the rule. And that's why you see 2-week quarantines as what happens.
And we're going to get to this in a second, which is why the danger to the healthcare professionals is so high, because if they're dealing with actual cases in a hospital, then those people are themselves infectious as they're there getting their care.
Oh, no question. And it's also why you see hospitals, for instance, ceasing having visitors. It's a very difficult decision to make, but it's all about safety. The fewer people you bring in, people who might be coming in, think of a visitor, a family member who comes in with somebody who has the illness and they're not sick yet, but they're 2 days before getting sick and they're infectious. And so it's all about lessening the spread.
Okay, so let's bring this local for a second. So here we are in Texas. So New York State, tragically, has over 92,000 cases today, which is just unbelievable. New Jersey is number 2, no surprise, right next door, 28,000 cases. And as of my most recent reading, which was a couple hours ago, we have 2,300, 2,400 cases in Texas, which seems like a very small number. We have 25 million or whatever people here. Is that because we're under testing? Is that because people, what's going on here? How did it get to Texas to begin with? Do we even know?
Well, we none of us know exactly, other than, there was a steady stream in February of travelers coming into the United States who were diagnosed with this at increasing levels. And somewhere along the way, with asymptomatic carriage and people like that, we believe you just started having some spread, and community spread in Texas and Houston showed up on March 11th to March 12th. Put that in perspective, then we've seen all of that march up come since then. And, we're testing just at Houston Methodist, a couple hundred people a day, and we're testing 30, 40 plus positive people a day, none of whom are getting it because they were traveling in China or anything else. They are community spread, and that's just our system. And that's just people who have more significant symptoms to the point that they get sent into one of our emergency rooms. That's not all the people who are minimally symptomatic, who basically either are staying home or getting tested at one of the community testing sites. So we've seen about 1,100 cases technically in the greater Houston area. I'm absolutely certain that's far underestimated in terms of the number of people that are in our community with this.
Well, we can get to a second. We'll get to testing. So let's get to Houston for a second. In the greater Houston area, what I'm told is there are nearly 1,500 cases.
That's about right.
And but 16 deaths, or at least that's what was reported most recently, which seems like a relatively low, thank goodness, mortality rate. So you think there's a higher incidence in Texas, then you're suggesting there must be a very much higher incidence in Houston itself.
No question. So, what you're seeing right now are people who have, in general, more symptoms. You're not seeing the people with fewer symptoms. So the good news is that's about a 1% mortality rate of that denominator. Just to define some terms, there's something called a case fatality rate versus an infection fatality rate. So most of the data you see out there is what's called a case fatality rate. People who were sick enough, they came to medical attention, they got tested, and then how many of those individuals die. That far overstates, we believe, the actual mortality of the disease itself, because people who weren't as sick didn't come to medical attention. Some of those people who were asymptomatic would be part of the denominator. We will not sort those data out until long after this is done through a lot of different epidemiologic techniques. Right now, it looks like the most recent data suggests the case fatality rate overall is around 1.4%. So much better than we saw early days in China, being reported at 3.5% to 4%, but nonetheless quite significant. And
Italy is like 10 or 11%.
I'm sorry?
Italy is like 10 or 11%.
Yes. And so what you're seeing there is a couple things. One is probably their denominator has not been fully identified. But the other you're seeing is when a healthcare system gets overwhelmed, you're going to have much, much worse results than when the growth stays within the ability of a healthcare system to care for people. And that's part of what happened, particularly in the Lombardy region and in northern Italy.
Can we have any confidence that the fact that it was 90 degrees here most of last week and is still drifting around the 70s and the 80s has any impact on this? There's a lot of misinformation about this. And one of the things misinformation was that young people can't get it. Well, they proved that wrong. Yeah. So the question now is, do we know whether or not warmer climates are going to be less susceptible to this because the virus lives less in a warmer climate?
So there's really two arms to that question and to that answer. One arm is transmissibility of the virus. So we know that that upper respiratory viruses transmit more easily in colder, drier climates than in warmer, humid climates. So that's why in the wintertime, we have a lot of these illnesses that we do have. And that's why, somewhere like New York was probably more susceptible than Houston. So I do think there's some good news in that for Houston, obviously, with the temperatures we have. The other embedded question that a lot of people are asking is, how seasonal is this? Will it go away when the summer comes along, like most respiratory viruses do, and like certainly the flu does? We just don't know the answer to that. There's a lot of people who believe because essentially the entire human race is naive to this virus. In other words, we haven't seen it before, that the dynamics that might lead to a seasonal burnout in the summer may not come into play, and we may see this persist. We just don't know. I do think if it did go away, it'd be good news, obviously, but it'll be back in the fall if we do.
But this gets back to the basic fact that a virus is not a living item. It is innate, right? And so if it doesn't attach to somebody, it just disappears eventually. Is that correct? Like a living cell does.
Yeah, I would phrase that a little different. I mean, it is living, but it requires a host. So it will need to go from host to host. And
that's why I'm a banker, Mark. I don't know that. I know what a host is. That's a party.
So, and so, yes, I mean, if it doesn't have somewhere to go, and that's why viruses can go away. And, there's really the ultimate way to have a virus go away is have what's called herd immunity, which is you get to a high enough percentage of people that it can't possibly transmit fast enough to infect enough people to keep going. There's only two ways to get that. One is almost every, 7, whatever the percentage for each virus is different. 70% or so of people have to get infected, or 70% of people or so have to become immune through immunizations, through vaccination.
Fantastic. So now let's get to Houston. By the way, let me remind our audience, if you're interested in posting a question for Marc later on, we are going to have the last 20 or 30 minutes of this presentation questions from the audience. So if you have any questions that are important to you, please post them, and I will get them here, and we'll present them to Marc later on. So feel free to do that. Marc, let's get to Houston. Are we anticipating more cases, and are you ready for more cases? And I'm talking about not just Methodist, of course. I'm talking about the entire medical center, the entire medical community here in our community.
Well, we're watching the numbers certainly with some concern, but also I hope some opportunity for some optimism, cautious optimism. So if you look at the modeling that we do, we're on the same trend line that New York was on, or that Wuhan was on, or that Northern Italy was on. We're just about 11 days or so behind New York City on that trend line. Now that's the earlier part of what is an exponential curve. And if you look at an exponential curve and blow it up, even the early part starts going up like you're showing, but it's small in the scheme of the overall curve. And we believe we're in that right now. The causes for optimism, one is, when you look at New York's, well, first off, when you look at Italy, it got totally out of control before anything was done. When you look at New York City, they had a pretty significant outbreak before really they started the dynamics that they had. And then, of course, I talked about temperature, but also you've got, the reality of geography and the stacking of people together in subways and everything else that you have in New York that you don't have here. So really the next 7 to 10 days is a very telling time for us, is where we are. We moved pretty quickly as a community to, as soon as there was community spread, really start shutting things down. We moved fairly quickly to get the stay-at-home order done, which is now 9 days old. And so
you made that. You were standing right next to the mayor and the county judge.
I didn't make it. It wasn't my decision to make, but we were there because, frankly, the medical community was working actively with them to show them data and tell them why we believed, as a medical community and unanimity across the Texas Medical Center, that this was the right thing to do. And just, with the order being extended just a couple of days ago, same deal. And Paul Klopman and I were both there to support the judge and the mayor, really to show that this is necessary medically. And it's all about what we just talked about. It's about that curve. If the curve flattens out, things are manageable. Unfortunately, a lot of people are going to get sick. Some people will die. And that's just the nature of this.
We're 11 days in. As you say, we're 11 days in. When will we have some indication that this order that was given last week is actually going to be effective? Will we know next week or week after? How will we see that curve trending? So,
most of the scientists basically say that to see the impacts of the social distancing, of all the things we do to sort of essentially stop all the nodes of people, interacting with each other close enough to be passing the virus, is a solid 2 weeks before you start to see that impact. So we're not there yet. We're getting close. That's why really this next week, 10 days, we're going to see this curve flatten out, and it's still going to go up. Don't get me wrong. Or does this curve go up very rapidly? We have scenarios modeling that basically show a peak in about 3 to 4 weeks if we are coming off that curve and flattening out. And it's a model that says we're going to be in good shape. We're going to be really tight on ICU beds, but we're all really creative. We're all able to expand that. We'll use more ICU beds than are in existence officially in our hospitals, but we will.
Let's get to that. So let's get to that, because that's obviously been the big issue in New York. It's been the big issue in other areas. The issue of shortage of beds, shortage of ventilators, for that matter, even PPE, protective equipment for our medical staff. What are we doing locally? Well, how is the Texas Medical Center and other medical institutions preparing for this? And are we where we need to be? Because New York was clearly caught off guard.
Yeah, and it just moved so fast. I mean, when it moves that fast, everybody's caught off guard. And so we have, I hate to say it this way, but the benefit of watching what's happened there. We never want to see what's happening there, of course, but seeing what's happening there, obviously we learn a lot, we see a lot, and it's there's a ton of work going on. But talking about a few things, the PPE, the personal protective equipment, we feel in pretty good shape with that. We've been working across the Texas Medical Center, our supply chain people together. I'd say for the key items, depending on the burn rate, which, goes way up, we're all 2 to 3 weeks out. In other words, we are in good shape for 2 to 3 weeks, but we need more shipments to come in, which are all underway. It's, there's sourcing happening, but they actually have to occur. We're doing lots of creative things to extend the use and many other things I'd be happy to go into. In terms of beds, in the model I was describing, we're going to be in good shape. It's going to be tight. In a model where this gets out of control, you're talking about a peak more like 45 or 50 days away. And you're talking about a model that is far beyond the number of beds, the number of ICUs that any of the hospitals, that collectively that the hospitals in Houston have. And that's where you're talking about, military hospital, staged up, field hospitals. You're talking about many other creative approaches. What we're trying to do is obviously keep it much closer to that lower curve as best as possible. That's why we've been so out in front urging, for the stay-at-home orders and everything else. I am, as I said, cautiously optimistic. I do think we did a lot of those things. You can actually look at some interesting internet data, or rather cell phone data. The cell phone data will say we've cut probably 55, 60% of travel and interactivity just by driving, which, you could impute then has cut at least that much in terms of social interaction. I think more, because you can still drive someplace yet stay 6 feet away from people and, other things that are happening. So there's reason to believe that a lot of the things that need to happen have happened through the sacrifice really of the entire community in those things.
So would you say the partnership with government, with other health organizations, including the CDC and others here in Texas is at a strong state and is working the way you would like to see it work?
Yeah, we've been working closely. Our biggest points of contact, of course, have been the city and the county. Have worked a good deal with the state as well, whether through the Texas Hospital Association or directly with the governor and the lieutenant governor. And FEMA has been in town helping as well from a federal government side. Frankly, this is by far the worst kind of disaster, right? The typical disaster, you reallocate resources from other parts of the country when a hurricane hits here or wildfires hit in California. Here, you've got everybody, maybe at different timing, but everybody needing the same things at the same time. And that's the biggest challenge, really, that everybody's facing.
So let's turn to the healthcare professionals.
Mm-hmm.
We've seen horrific stories and news of what's going on in the hospitals, for example, again in New York and of course in Italy and other places. What's the front line like in our community?
Well, yeah, it's a great question, and it's a rather strange time in hospitals because we down-regulated so much of what we normally do in order to free up space, which is absolutely the right thing to do. So actually, the census in our hospitals is lower than it would be on a normal day. But then you have this hotspot of all of these patients who are in-house, who are being cared for, and employees right there on the front line. And so you run the gamut from employees who are right there struggling at the front lines to employees who are working from home to employees who are clinical, but maybe in an area that we're not running right now. And so it's a very odd and unsettling time for many. The hardest, of course, is the people who are on the front lines. Our number one priority always is their safety, and the PPE and other things is critically important. Everything's data driven, national and world recommendation driven in terms of how to do that. And they're hanging in there. I mean, these are people who, this is what they tell me. They basically say, look, this is why I went into medicine. This is what I've trained all my life to do. And, the physicians take the Hippocratic Oath, nurses and others take other kinds of oaths and other kinds of pledges as they get their degrees. They know that there's sacrifice involved in that. They know there's risk involved in that, whether it's wartime or epidemics and pandemics, nurses and physicians and other clinicians, have a long, storied history of being involved in tough times like this. And so they're hanging in there, but they're working hard.
So here's my first question from the audience. Have you had any sleep?
Me?
Yes.
Yeah, it's been a long haul, as you can imagine. It's just like in a hurricane. I've been through a bunch of disasters in my time here. That first 4 or 5 days, you're so wired that as soon as you have 4 hours of sleep, you wake up and you're ready to go. And now this has been going for a month, and so there's a certain point where you're tired enough, you're getting your sleep. But they're long days, as you can imagine.
This is like
they're long days for all of us.
So you're back to med school, basically, is the way you are.
Yeah, we've been through the drill. It's a lot harder my age now than when I was 20 something. But yeah, we've been through the drill before. And the bottom line is, I preach to everybody. We're running a quadruple marathon here at least, and so we all have to take care of ourselves. So I do try to practice what I preach. But
one element of this, it sounds like you haven't hit this yet, but eventually, and we've seen this in other cities, there is a mental and emotional component to this, not just the danger of being in the front line. As you've explained, patients, infect others, and they can affect the healthcare workers. So every day they're there, they're running into a burning building.
That's
like
right.
a fireman runs into a burning building, these healthcare people every day, they come into a ward where there are either just one or maybe multiple people suffering. They're running into a burning building. Is there an emotional and mental component that you can also deal with somehow to help these actually heroes make it through what could be a very long period, as you say, a multiple marathon race?
Yeah. No, and you're right. They are heroes. I mean, that's the perfect description. And really the frontline people, all the way from obviously emergency care workers, police, fire, et cetera, all the way to the folks at the front line in hospitals are heroic in this situation, and always, but particularly now. It is tough. It is stressful. When you talk to them, they're all hanging in there. We're a faith-based institution. We're very employee-centric and patient-centric. And so there are all sorts of things being done to help support people through these tough times. Many people really burning the candle, long on both ends. And when they're there, it's tough and it's stressful. Just this morning, actually, I did a roundtable with 3 of our frontline folks to then do a video to share with our team members with 26,000 employees. And to a T, I mean, they are all so dedicated, but to a T, they talked about, and I asked them about the stresses of that. How do you go home to your 4-year-old and your 7-year-old and not worry about bringing home something to them? How do you unwind when you're at home and take care of yourself when, you're not there? And how do you turn things off and get some mental break? All of those are really challenging things for sure.
So one of the things you just referred to, and I know some people are concerned about this, is you basically emptied out the hospital. So you canceled elective surgeries, you canceled all sorts of other medical care that you would otherwise have in your hospitals or throughout the medical center. This has to be financially a challenge for the industry, for the business.
Oh yeah, no
of hospitals
question.
and healthcare. How are you dealing with that? What is the general mood of that among administrators like yourself and others in the medical center?
Well, it's one of those, I try not to look. It's sort of like looking at your 401k right now. Just don't look for a while, it's seriously though, we purposely turned off all of the elective side of things, and so we are here for people who need care. Let me be really clear. But of course, a classic example is a hip replacement. That can almost always wait. Somebody may be in pain, their physicians may be managing their pain. But in terms of when you time that, now's not the time to do that, for example. Now, if somebody falls and fractures their hip and they come to our emergency room and they need a hip replacement to treat the fracture, of course, we're doing those. Of course, we're there for heart attacks and strokes and everything else. So we're very much still, seeing a lot of patients. That being said, our outpatient surgeries are down 75%. Our inpatient surgeries are down 50% because our clinicians have looked and said, if this can safely wait and there's no deleterious effect to the patient of waiting, we're going to wait because that's the right thing to do. You don't use protective equipment. You don't fill up beds with patients that are not COVID, et cetera. It's all getting ready and having that capacity there. The way hospital finances work as the financial end of that is that really there's this big S curve, and there's one end of the S, which is pretty small, which makes a lot of the profits. There's another end of the S, which is bigger, which has a lot of money loss. And most of the S is kind of right around break even or even a little bit negative. Well, everything on the good side of the S financially is basically the elective side of things and diagnostic side of things and others. So we've turned off all the good parts of the finances of the hospital. So it's pretty amazing when we look at some of our financial projections.
For example, the emergency rooms, which is where the other end of the S is, I think, right? Have to be open, right? You have to take in critical cases of people that have access to those things, right?
Absolutely. But, even our emergency room volumes are down right now. The COVID's way up, but, a lot of the normal follow-up and other things, a lot of it's being done digitally and other things. So as I said, it's a very strange time. So, put it into perspective. We're licensed for something like 2,300 beds. We run pushing 2,000 beds across our system. We have about 110 to 120 patients with COVID in-house right now. But my census across the hospitals is far lower than it would normally be, which is a good thing. I mean, it's a really good thing because that's the capacity that we've stood up to be ready to then surge and take care of more patients. And there's many, and a lot of the state licensure and other things have been waived. So we can go from, 2,000 beds probably up to almost 3,000 beds across the system through lots of creative ways. You take a post-anesthesia area and you turn it into a makeshift ICU because you have all the equipment there, you have the beds there, you have the oxygen there, you have the ventilators, et cetera. And so you'll see us, if we have to, surge dramatically in place before you start resorting to outside of hospital ways to expand.
Okay, so let's talk about the future. And the issue you talked about a few moments ago was flattening the curve. What would be the more drastic steps we could take to ensure that curve was going to flatten? Is it they talked about in the China case basically cordoning off the entire city of Wuhan, basically the entire Hubei province. They basically cordoned it off, and they are telling us that there are no other cases basically in the rest of China, other ones that were imported, and because they just shut the whole thing down. As you think about the worst case scenario that could hit Houston or hit this region, South Texas, Southeast Texas, what would be the next step that you would recommend to the officials to say we've got to flatten this curve, and this is the only way to do it?
Yeah, in American society, Western European society, it's a lot different, obviously, than China. Shutting down the borders of the greater Houston area, as an example, really would probably be, in those scenarios you're describing, be more about protecting everybody outside of the greater Houston area than protecting everybody inside the greater Houston area.
Well, I think that's what it was in the Chinese case, right? I mean, it was let Hubei and let Wuhan specifically suffer, but not let the rest of the 1.3 billion people get infected. And I guess that's what you're talking about.
And what ended up happening there is they were able to then source and resource a lot of things from the rest of China into that province. And even so, we saw the devastating toll it took. Here right now, we've got wildfires spreading literally almost every big city in the United States. I mean, there really is no large urban area that isn't somewhere on the curve of New York, just earlier. Now, Seattle was one of the early hotspots. They've managed to not look like New York. Same thing with some of California. The hottest spots right now are New York, northern New Jersey, particularly northern New Jersey, all of New Jersey, but especially the northern part. We're starting to see Chicago, Detroit, New Orleans, most close to us, are really the farthest along. There's a great hope of all of us that we can keep that flatter in these other cities because of the actions that were taken. But quite frankly, we still have something like 11 or 12 states that haven't gone to a stay-at-home order. And it took a long time in the state of Texas to get to that point as well. And there was good rationale for it. The Texas Hospital Association pushed for that 10 days ago. And, it ended up going county by county in the places that mattered most. And then Texas Hospital Association and others pushed for that this weekend. And the order was made, at the beginning of the week. Really, because in that week, we saw the counties in Texas go from about 50 to go to over 100. So you were at pretty much half of the counties in Texas. And small town Texas is less able to handle this than really the big urban areas. I mean, think of a small town with limited hospital resources, and then this spreading like wildfire in one of those areas. So we're very glad now that we've got those orders. But when you ask the question of what more is there, there's not tons more from that, right? We do have a lot of exempted industries. You might have to cut that back some further because some of those, you could debate whether they should or should not be exempted. Really, it's more about people listening and following. I mean, if everybody listens and follows and does this, we're in much better shape.
Yeah.
We're not seeing that.
You would think that people have been told enough as to what to do. But however, let me just give you an example. Today, all of a sudden, the federal government said at the end of the day, evidently, they said, oh, you should be wearing masks now. Now, for the last 2 months, they've been telling you don't have to wear masks. It's not an issue. All of a sudden, of course, everybody in China, everybody in Singapore, everybody in Hong Kong has been wearing masks for months. And in fact, everybody in Asia wears a mask even when they catch a minor cold because that's a social norm. It's a gesture to the others. Should we always start wearing masks now? Is that our next?
That's a great question. The data is not there one direction or the other. Probably if there's a benefit of it, it's much less about me protecting myself. So if I wear a mask out there, because this is droplet spread and not respiratory spread, that mask is probably not protecting me. In fact, there's some data to suggest, because I'm going to mess around with it and fool around with it and other things, that I may be more likely to sort of self-inoculate this because I've touched some surface. Now I'm messing with my face more often. Where it may be helpful is actually protecting others, because if I've got this and I'm infectious 2 days before I'm symptomatic, and maybe I'm coughing a little, clearing my throat a little, whatever it is, and I'm actually leaving some of the virus someplace for someone to pick up, a mask actually will block that. And so for that reason, actually, over the last week, all of the hospitals went to universal masking of our clinical personnel, basically at a time where there was enough prevalence of the disease where we knew that it was another safety measure to take. But very candidly, the data isn't there to 100% support that, but we had enough PPE in place and we knew that we could handle it, and we knew that it was the right thing to do. And so all the hospitals in the Texas Medical Center synchronized around doing that together. In the community, the reality right now is, twofold. One is the data is not there to clearly support that. And two is the PPE is not there. And we have, it may sound selfish, but we have to protect the frontline people who are, with people with high volume of, and high infectivity, and we have to protect them. I do think we may get to a point where we do that. I do think we may get to a point where it becomes a different social norm in the United States when we are sick. But right now, what we'd urge most is social distancing. Try not to interact with anybody you don't need to interact with outside of your home. And when you do, 6 feet away, because you can't infect somebody 6 feet away. You just cannot. And you're not, unless you're touching surfaces. Wash your hands, hand gel frequently. Don't touch your eyes. Don't touch your face. Try to avoid those things. We all do it, but try to cut it back.
So I want one more series of questions. We've got about 20 minutes left, and I've got a number of questions that have come in from the audience, and I thank everybody for that. Oh, by the way, I think you might have noticed that Robert Kraft sent his private plane with the Patriots on the side of it, by the way, and collected 1.4 million masks from Shenzhen today and delivered them to Massachusetts and I guess to New York. So there are people out there all over the world, I think, trying to help the
well, and I'll give a shout out to Jim Crane, because Jim Crane of the Houston Astros, his business is logistics, and he got on the phone with me, right at the start of this and said, let us know how we can help. And he has been helping the whole Texas Medical Center get things to the Texas Medical Center. He's donated a lot of that. So he and the Astros have been really great as well.
Well, I went on the 3 or 4 websites today and tried to get those little flimsy little blue masks that I presume do absolutely nothing. And the earliest you can get them delivered is sometime in mid-May. So, it's almost not worth talking about to begin with. So let's talk about the mortality rate and how we reduce the mortality rate. Houston Methodist proudly was the first hospital, as I understand it, that actually performed above plasma transfusion on Sunday after the FDA approved it on Saturday. I believe that's correct, isn't it?
Yeah, actually, it approved it Saturday, and we did the first one on Saturday night, the second patient on Sunday.
Okay, and what do we know about that? Do we have any feedback yet? Or how's that looking as a possible solution?
Well, it's very intriguing and very theoretically promising. Let me put it that way. So for 100 years, people have used this, and it's basically the theory that says, look, if I get the disease and a couple of weeks later, I'm now immune and I've got antibodies in my plasma and the liquid part around my blood, why couldn't I take that liquid part of the blood, give it to somebody who has the disease, and I've right there given them, immunity passively that they are going to end up being able to utilize. And so we did that on an emergency use basis with the FDA. I'll give the FDA credit. I think it was 52-minute approval for the first one and an 11-minute approval for the second. So they were prompt and really on top of this. This is a precursor to a large multi-center randomized controlled trial that we're part of, and many other institutions are. The idea, again, is that you can help someone right now. It's being looked at in the critically ill, but there are theoretical reasons to use it in 2 other populations. One might be the sick person in the hospital who you're worried about declining and needing an ICU and stopping that process. And the other may even be preventive in healthcare workers or other people who have high levels of exposure. So this is going to get ramped up very quickly, but it is being studied. We're figuring out, A, is it safe, and B, is it effective? Far too soon to tell in our 2 patients. These are critically ill patients where even if it works,
other hospitals, I understand Mount Sinai and other hospitals are experimenting around the country with the same treatments. Is that right?
That's right. Mount Sinai, shortly after us, or maybe even almost simultaneous with us, I'm not sure the exact timing, also did their first patient. I don't believe anyone else has in the country yet, to my knowledge. There's about 70 plus large academic medical centers all collaborating on a large multi-center trial. This is like a blood donation. So it takes an hour of a patient sitting on the machine and giving up the plasma. And then between turnover and cleaning the machine and everything else, you're really talking about a cycle time of almost 2 hours. So the reality is you can't get mass quantities of this. This isn't the panacea for everyone.
And it has to come from someone who suffered the disease and is at least 2 weeks asymptomatic.
Right.
Right. So
right. And then they're tested
to begin with.
Right. And then they're tested to see if they have the antibody. Now, the good news is the antibodies. The good news is that one person with one donation can treat 2 patients. And because it's not like a blood transfusion, or blood donation. It's not a large volume. So they can actually do this twice a week. So when we get that whole cadre of volunteers like that, you can actually, one person each week can help 4 other people with this. And so it is very promising. And where it's particularly promising is if it works, then and when we can identify the antibodies that are active, there are other techniques to perhaps create antibody preparations separate from this that could be much larger and could be used in preventive or in treatment settings. That's probably 4, 5, 6 months away to get to that point.
Okay, so then the next one that the president has talked a lot about is I guess a longstanding malaria a drug called hydroxychloroquine. Did I get that correct?
Yeah, pretty good. Yeah, pretty good. We'll get you your honorary MD soon. It's hydroxychloroquine and chloroquine, 2 different versions of the same drug. Long-standing malarial drug, and then in more recent times, if you've heard of the drug Plaquenil, it's used for rheumatoid arthritis and some other autoimmune disorders. And so the drugs are pretty readily available till there was a run on them because of all the discussions nationally about it. And there's some intriguing data. It's preliminary. It's far, far, far from certain that hydroxychloroquine may have some efficacy. Then there was a small study out of France, very small number of patients that added a Z-Pak or azithromycin to that. That also has some interest. The challenge is, and this is where the medical community's really been trying to tamper down some of the expectations, is A, we don't know that it works. B, all medicines have side effects. And C, the combination of those 2 drugs actually has a potentially lethal arrhythmia or rhythm disturbance that can happen as a result of it. So it's not, if I were to try to prescribe that to patients in the outpatient setting on a routine basis, like say I had a patient with rheumatoid arthritis on Plaquenil and I said, oh, you got a upper respiratory sinus infection or something, I want to give you a Z-Pak, my alert would be going off on my computer saying, are you sure? Because this is a potentially dangerous combo. So it's being used in the clinical setting as an inpatient, and that's really the appropriate place to use it. It's not something that the general public should be, certainly not the combination, should be reaching out and using at this point in time.
So those two are types of cures of existing sufferers, or something to lessen the risk of mortality.
We hope. We don't know that. We hope.
Yeah. And now we're talking about vaccines. So every fall we're told get your flu. You go get your flu shot, right? And older people are told to go get 2 flu shots. I don't know. I think I had 3 this year. Obviously that's not working now. Are we going to have a COVID-19 or some equivalent vaccine within the foreseeable future, maybe even by the time we get back to the flu season in the fall of 2020?
Yeah, it's not going to happen by the fall. It's a 12 to 18 month process. We've heard that from Fauci, and he's correct time and time again. Let me put that in perspective. Most vaccines take 10 to 15 years to develop. Nowadays, thankfully, there are some different techniques that, frankly, it's a massive triumph of modern medicine that Moderna, for instance, has an RNA vaccine that's already in clinical trials, and there's a couple others as well. To do that in 3 months, honestly, was absolutely remarkable. But when you start thinking about any drug, any vaccine that you're going to give to millions, actually maybe even billions of people, it has to go through a lot of process to A, figure out, is it safe? And B, figure out, is it effective? And C, figure out in what kinds of dosings and regimens that it's effective. So it very well may get rushed to market in sort of a good enough status versus, what would be the ultimate vaccine. I think that's possible, but that's going to take a solid 12 plus months to get there. And that's just, unfortunately, the reality. Now, if you were dealing with Ebola, and you had a 40 or 50% mortality, obviously the risk benefit would change. And if you could develop anything, you'd probably start giving it to the front lines, recognizing that, the cure is better than the disease in that case. But we got to make sure that the cure is not worse than the disease.
Yeah, okay.
You never know that until you actually study things.
So
vaccines are incredibly safe. I mean, absolutely safe. But the reason they're incredibly safe is because they're well studied and studied across broad populations in, very thorough, careful trials before we go give a large population of people the vaccines.
So, Mark, we have 10 or 12 minutes left, and we've gotten a flood of wonderful questions, and I have a few here that I want to get to you. Here's one that could be very interesting. Is there any information on how COVID-19 affects early pregnancy, or any pregnancy for that matter?
I'm not an obstetrician, but I've read enough and listened to enough of my colleagues. Right now, there's really no suggestion that I'm aware of that says this has any detrimental effect on the baby or the fetus. Unlike some other, German measles and a number of other things that are things that we worry about during pregnancy. Obviously, we want to keep our pregnant women safe. There's a little bit of concern that at certain times of pregnancy, probably around delivery, especially, the mother may be, more susceptible to more severe disease. So, we do consider that a vulnerable population. We don't know all the data. So when I think about people we should be protecting, certainly pregnant women are very high on the list.
So here's a very interesting question. Someone says, I've read that 2/3 of patients put on ventilators pass away anyways. How do you determine who should be put on a ventilator? Is that true? The 2/3 of people that go on a ventilator actually pass away?
We don't know that answer yet. That has not been our experience to date. And so, we're very, very hopeful that it can be far, far better than that. It does not, it looks to be more challenging than the flu because, every year, remember, we put many people on a ventilator who have the flu. In fact, we put people on artificial lungs, what's called ECMO, with the flu every year. Oftentimes a 25-year-old who's otherwise healthy. It happens if you have enough people infected. We've managed to get people off of ventilators. We've actually managed to get some people off of ECMO that are on ECMO right now. There is a good fighting chance here, but the mortality once someone is in the ICU and on a ventilator, no question, is significant. I couldn't tell you we know that yet.
Mark, are the majority of people that get to that stage sufferers of other health issues before they get there mainly? I mean, is that a relatively high percentage? People with asthma, people with diabetes or other things that are also just challenging, making it so the ventilator can't actually do exactly what it needs to do?
Yeah, there's clearly age is a major risk factor, and then underlying health conditions are a major risk factor for death. That doesn't necessarily, and that does correlate with, need for ventilation and other things. But let me be clear. I mean, we have people at Methodist and have treated people at Methodist really across any adult age range that have required a ventilator at this point. We're getting people off of it. And obviously younger people are more vital and even with underlying conditions, more likely to do that. And if you look at, there's actually, and I'm happy to send out some slides after this. I think we may already get
we couldn't put them up today, but if you send us some slides and people ask for them, we'll try to forward them along. Okay?
Yeah, and the reason we gave them was because it's a nice resource. So there's one of the slides in there that's from MMWR. It's Mortality and Morbidity Weekly Report. It comes from the CDC.
You got to rename that, Mark. You got to rename that.
MMWR. Yeah, it's a medical deal, but you'll see it. It's a bar graph, and it's basically a study of a couple thousand patients in the U.S. Some of the early experience. And what you see on there is people in every age group except for the 0 to 19. The good news is almost nobody's getting admitted to the hospital in that age group. But from 20 and up, there are people getting admitted to the hospital. There are people getting ventilated across the United States in those age groups. But the mortality rate is very, very low in those younger groups and then increases with age. And even in the 85-year-old and up group, the mortality rate is actually higher than the ventilator rate. And that's because you may have a 90-something-year-old, for example, who, is very ill, has dementias in a nursing home, and where, family members choose not to ventilate and choose to to use palliative care. But you see the mortality rate going up with that. But there's a fighting chance here, a very good fighting chance, to care for people, even with a ventilator, even with ECMO. But again, that comes back to that fundamental issue of we can't overwhelm the hospitals. We can do amazing, sophisticated medicine, but not so much if obviously we are in essentially wartime conditions, like you're almost a field hospital, triaging patients coming in from a battle. That's what we all want to avoid. And unfortunately, that's what we're seeing in Northern Italy, and we're seeing in New York to a certain extent also.
So there's been this debate about, okay, and here's a question that came in: what are the downsides, the risks and downsides? You just quarantine only high-risk people and allowing the economy to open a little bit so that maybe we get more immunity by people who can suffer the disease and live through it, but go back to work, as opposed to just making sure that we're protecting those people that are in a higher risk category, not just age, but health conditions and other things. What is your thought about that debate?
Well, the problem right now is essentially the genie's out of the bottle, right? This is everywhere. It's spreading everywhere. You don't know everybody who has it. It's far too fast of a growth. So if you were to try that right now, I can guarantee you're going to see every city in the United States and then subsequently every small town looking like New York City. You will overwhelm hospital capacity, and you will have young people dying because they can't get access to the health care that you need, because there will be a percentage of young people at every age who do get particularly sick. The people are getting really sick. It looks to be a hyperimmune response effectively. They get what's called a cytokine storm. So their body almost becomes its own worst nightmare because it shoots out so many different things to try to kill the virus. And so that's not a viable strategy. Now, what is a viable strategy, I do believe, is you have to get the genie back in the bottle. You have to get on the other side of the curve. You have to get to where this is pretty low prevalence. And then there will be strategies, and this, none of us know exactly how this will work. And there's going to be fits and starts, and there's going to be some quarantines that come back in and some stay-home orders that come back in at different times. But you have to get to a point where you start opening up the economy for sure. I think there'll be a population of people who are going to need, for a prolonged period of time, to be more protected, the more vulnerable. But we're going to have to figure out ways, and we're going to have to live with social distancing. I'm not saying stay-home orders, but I think you can count on many, many months of you're going to stay 6 feet away from people, and you're going to be washing your hands all the time. We may all be wearing masks, for instance, at some point in time. We may be checking temperatures at every place of business, at every public congregating site. We're going to need massive testing ability, and we will look at big populations of patients with probably what's called serologic testing, which is blood testing, to see who's got it and doesn't, and try to figure out populations of people who have had it versus haven't had it. It's going to take a massive investment in public health infrastructure.
So that refers to one or two of the questions we got here. There are people that were asymptomatic, had the disease, asymptomatic, never got sick, and are going to walk around and never know they had it if they don't. Now, would we eventually test those people and find out that they did have it, and perhaps they're therefore immune, or what?
Yeah.
Is that true? Is that a possibility?
I think that's a distinct possibility. There's actually a trial in Telluride right now looking at the population. I think there's 8,000 people there right now looking at the whole population to see if they can do that. Just so happens one of the companies is, and I think the two founders are based there. And, serologic testing is coming online, but serologic testing is not particularly useful for diagnosis. If you're lucky, maybe somebody in the first few days of illness has the antibodies, but really where it's useful is 2-3 weeks out when you say, yes, you've had it. And for sure, there will come a time when we're testing all healthcare workers, all frontline people. But I think there's a distinct possibility we'll either be sampling or even testing large swaths of people, with probably rapid 5-minute, finger stick, maybe not the perfect, most sensitive test, but enough that we're going to be getting that. And theoretically, people with antibodies should be immune, but we don't even know that 100% sure right now. But there's every reason to believe that's the case. Yes, and we may have situations where we know, I may, for instance, in the hospital, have a situation where I'm like, okay, this 20% of my workforce on the front lines, you've had it, you've gotten through it, you've got the antibodies, you're our first responders, right? And then even sort of segregating duties that way may happen.
So the way testing goes today, as I understand it, is that you have to fit some sort of a profile, right? You have to have symptoms of some sort or another, and some people are turned away because they don't have serious enough symptoms. They could still have COVID-19, but they don't have serious enough symptoms, and so eventually if we had enough tests, everybody should get tested, shouldn't they? I mean, why
Well,
wouldn't
at some point. So the question with so two kinds of testing. So right now we do what's called PCR. That's the nasopharyngeal swab in the back of your throat, or if you're coughing stuff up, we'll test that. That is very sensitive if you get the sample, and then you may not have it present in the right place of your body to be there. But if it's there, it's very sensitive. The problem with that is it's not really a screening test of, hey, everybody walking around, go do this. It's useful once you start really replicating the virus, meaning maybe a day or two before you show symptoms, and then from the time you have symptoms. What's happened in the country, as you all have seen with the CDC decisions a couple of months ago, we don't have the mass testing capability that should be there from the public health infrastructure. Thank goodness that academic medical centers like Houston Methodist and many others stood up their own tests. We did our first test in January as a trial run. And, we're doing 200, 250 a day right now. We've done 2,500 tests across our system. But the people who come to us are coming and getting screened and coming to our emergency room because they've got enough symptoms that their doctor is saying, you got to go. I got to check you out. You're sick enough. I'm worried about you. So it's a much higher acuity population. In fact, so we've had about, 425 people test positive so far. About half of those getting admitted to the hospital, and the other half going home and getting cared for at home. Of the people admitted to the hospital, we've sent over 100 people home, which is really great.
Mark, let me ask you, if you caught it earlier, let's say if you caught it very early, just after the second day after infection, but you were asymptomatic, could you as a healthcare provider do anything differently, or is that going to get sick anyway? So I guess the question is there a cure because somebody's got it early on and you can somehow stop it from proceeding on to the full illness that we're seeing people get? Because that's, I think, what some people say, well, I want to get tested now because, maybe I can stop it from getting worse. And so
yeah, the reality is I wish that was the case. We'd be in a really different situation. Obviously right now, that'd be like the flu and Tamiflu, for instance, where we test for the flu and you can shorten the disease and decrease viral shedding and infectivity and everything else. With that, you can actually treat household contacts with the flu with it and try to prevent it. We don't have anything like that. So yeah, it's hard fact for people to accept, because I get it. But the reality is if you've got mild symptoms and that's all you got, you need to be staying home right now. You need to be quarantined. Most of us are staying home anyway. And because the testing is in short supply, you're not going to get the test most likely at this point in time. Once the community resources for that ramp up, and all of us are working furiously. I mean, we're trying to get to where we can do thousands a day, but there are backlogs on the chemicals we need and some of the extraction kits we need to get the DNA or the RNA material from this. And so it'll get there, but it's going to take a while. And really, before the U.S. starts turning down the restrictions, that to me is the fundamental thing the government has to solve. Not because you need to know, I'm getting symptoms. Do I have it? Because we need to treat you differently, not because we have a cure, but in terms of how we quarantine you and how we keep you away from it and how we follow the people around you. This is the massive public health side. We need to, again, have the serologic testing, and we can go out there and test the whole population of people and say, okay, this 10% of people, check. We don't ever need to worry about you because, other than rare cases, you're not going to get the disease again, and then focus on others. And so a lot of that's going to have to come online. It's being worked on fast and furiously. But the reality is, if you go get a routine test and send it to LabCorp and Quest now, you're talking 5, 6, 7 day turnarounds. It's pretty much useless. I mean, if you come to Methodist and you need to get admitted or you're sick enough to be in our ER, we got a 16-hour turnaround because we have our own test. So we can answer the question and then deal with it. But the reality is, if we're sending you home, you're not getting any different treatment, whether we sent you home and we had a 16-hour test or a 7-day test. We just know, and we know one way or the other better.
Well, so there's one question that's come up a couple of times, which is interesting. Houston's changed. It used to be a very sprawling city. It still is a very sprawling city, but we've also built a lot more multifamily apartments, some high rises, some large, and there are more people closer in, not as badly as New York or some of the other large cities where this has become a real problem. Is the incidence of infection obviously higher in denser places like apartment buildings, and there's just some things people there can do? For example, the air circulation system in a condo or in a multifamily unit create a risk for people living there that wouldn't exist if they lived in a single family home.
So this is not respiratory spread. So that's the good news. If this was measles, you can infect 20 people if you've got the disease sitting in a conference room with them. This is not respiratory spread. Now, in the healthcare setting, you'll see higher level masks because procedures that are done might aerosolize this, and then it can be respiratory spread. This is spread through droplets. So I could give it to you if I stood right in front of you and sneezed all over you or coughed all over you for sure, right? But most likely where it's happening is I'm coughing, it got on my hands, I hit the elevator button, I turned the doorknob, I held the railing on an escalator, and those things aren't cleaned. And then the next person comes behind me and touches that and touches their eye, touches their nose. So the reason you'll see it more likely to spread in a denser environment is because there's all those surfaces that many people are touching. So the way to avoid that is you got to have much more significant cleaning regimens for common areas like that people touch. I mean, I don't touch elevator buttons now. I do it with my elbow, seriously. All those kinds of things. I've got a little jar of hand gel. And when I know I've touched something that's a pretty common surface because I didn't have a choice to, I pull out the hand gel and I do my hand hygiene. And we've got to all be in that mindset of doing those kinds of things. And that's really the reason. The air systems are not something to be concerned of in those environments.
That's great information. Marc, thank you so much. I want to give you a moment or two. If there's anything I haven't asked you or other messages you want to give to our audience, I know they're all very, very interested in your commentary. And if there's anything else that I've left out, please feel free to carry on for a second.
Well, thanks. And thank you. You've asked great questions, and I've been happy to help answer them. And, I think the most fundamental reason, the reason why you've seen medical leaders standing up there with politicians about stay-home orders, and why you see all the communication, why you see us on TV and the newspaper all the time, is we're all in this together. And frankly, if we don't all kind of carry out our societal, I think, obligations to keep each other safe, this will be a lot worse than if we actually rip the Band-Aid off as we've been doing, suffer together for a shorter period of time, and then start figuring out how to get life back to normal. And so really where people can help the most is continuing to do the things that they have embraced and done. We get that it's really tough. It's a big sacrifice. As a primary care physician, I worry about my patients, and I worry about, psychosocial issues. I worry about stress. I worry about anxiety. I worry about depression, people with mental illness. I worry about elderly people who we know that shut-in status and social isolation are actually bad indicators for the health of an elderly person. So while that's a necessary evil now, how do we all work together to make sure that we're reaching out? And, social isolation is really physical isolation, but socially we're connected even more than we are before through digital means, through telephone, everything else. My parents, my wife's parents, they're holed up in their homes right now, but I swing by. I don't ever go within 6 feet of them, but I swing by and check in on them multiple times a day. Multiple times a week to make sure that we're keeping that connection. The kids are calling them, looking at them, all those kinds of things. We're all in this together.
This is particularly hard on grandparents and great-grandparents, I'll tell you that. And we're having a tough time as grandparents. But Marc, this has been incredibly informative and valuable. I want to thank you personally, but I also want to thank everybody in the Texas Medical Center and in the medical institutions across our community. I know we think about the Texas Medical Center as a single place, but I know there are hospitals all over our community. They're dealing with this crisis every day. This is a human tragedy of immense scale. And without people like you and your dedicated colleagues in this field, it would be much, much worse. I can't imagine what this would have been like in 1918 during the Spanish flu. It would have been horrific. And so we thank you for all you do. And we thank you for joining us tonight, the Asia Society.
Thank you, Marty.
Let me make a couple closing remarks to our audience. We thank you for joining us. As Selena started, we are going to have a weekly series of conversations about COVID-19, Thursday nights at 7:30. So next Thursday, on April 9th, the program will be Fact versus Fiction, examining the spread of COVID-19 misinformation. And I think we all, if you watch any TV, you're going to get different opinions about everything. You've got the straight story tonight, so you don't have to worry about misinformation this evening, but there is a lot of that out there. And next week, we're going to examine with a panel what's the spread of misinformation. And then the following week on on Thursday, April 16th, again at 7:30, the topic will be the economic and financial impacts of coronavirus How do we get back to normal? And I'm going to moderate a conversation with Ali Velshi. Some of you may know Ali Velshi. He is a very well-known business commentator. He's been on CNN, he's been on Al Jazeera, and he's now presently on MSNBC. Ali's been to the Asia Society a couple of times. I interviewed him last year. And he and I are going to have a debate on what is the impact on our economy, locally, nationally, globally, and what's the outlook for this side of this crisis. So look forward to both of those programs, and there'll be another program the week on April 13th that we'll announce later. We thank you for your participation. If you want to learn more about those upcoming webcasts, go to the Asia Society Texas Center website, and you'll be able to find those details. In the meantime, thank you all for joining us. We appreciate it, and please be safe, be healthy. Thank you.
Thanks, Marty.